Good morning and welcome to my YouTube channel, Pain Free Partha. Today's topic is about obturator nerve block. I will try to make it a little easy with some small simple illustrations. So, selective obturator nerve block was first described by Labat in 1922. So then after that it got less interest. It's difficult to do and it is not that successful. It is difficult to analyze and see whether it is working or not. So then it started going down. Then obturator nerve block combined with blocks of sciatic lateral femoral cutaneous nerve SC can block the entire lower limb. So clear landmarks, block complexity, inconsistent results. That is why it faded. So Labat's classical technique remained forgotten after it was modified by Parkes. It was modified by further Vasov, Pinnock in 66. In 1973, Winnie introduced the concept of 3-in-1 approach to the lumbar plexus. That is what is the hit for some decades. Simple paravascular inguinal injection to anesthetize these three nerves. Its description, how many studies have refuted the ability, whether the three nerves are getting paralyzed or not, reliably getting paralyzed or not, has been refuted by many studies. Now I will tell in those days there are two differences between a femoral nerve block and a 3-in-1 block. In a femoral nerve block, you see just palpate the femoral artery and gives laterally after a pop 10 ml. This is what is called femoral nerve block. So if you palpate the artery and then give after the pop 30 ml with a distal pressure, then it became the 3-in-1 block. It is supposed to paralyze or anesthetize femoral nerve, lateral femoral cutaneous nerve, and obturator nerve. Partially, the lumbar plexus is getting paralyzed. Now we will go to the anatomy description. Before that, all these obturator nerve became very familiar after the introduction of the ultrasound. The obturator nerve arises from the anterior rami. That is what is important. Femoral nerve, it may think that actually it is posterior. Obturator nerve arises from the anterior rami of L234, goes just at the medial border of the psoas major muscle. Okay. Now, after it travels down the iliopectineal line, it descends through the muscles of the psoas major and then cross into the pelvic beam here. This is the obturator nerve. And in the obturator canal, that is what is the obturator canal, it divides into anterior and posterior divisions. The anterior branch continues. Where is it? Longus, brevis, magnus. 3 adductors. Longus, brevis, magnus. In between longus and brevis, and continue to extend as the sensory nerve for the medial inner thigh. Medial lower thigh. The posterior branch travels between brevis and magnus. What is the first one? Longus and brevis. This is brevis and magnus. And go to the knee joint. Now this is the obturator canal. It divides into anterior and posterior branches. The obturator posterior branch is here and the anterior branch is here. You can also see this obturator externus, the division of the anterior and posterior branches. Now I will tell in the cross. This is pectineus. Longus, brevis, magnus. 3 adductors. This is the obturator externus. Now it comes the obturator nerve. It divides into anterior branch and posterior branch. The anterior branch comes between what? This and this sometimes. Pectineus and brevis. And then goes between longus and brevis. This posterior branch, longus and brevis. This is longus and brevis. This is brevis and magnus. Now you can see the obturator artery also. Whenever you target your local anesthetic here as a single injection, then it becomes the proximal approach. Then if you go belong this, goes one injection here, one injection there, anterior and posterior are separate injections. Then you call it as distal approaches. The obturator nerve provides articular branches to the hip-knee joints. Anterior branch will supply the hip joint and posterior branch will supply the knee joint. There are some accessory obturator nerves. This is the obturator nerve, which is in yellow. This obturator accessory is in green. Sometimes it innervates the hip joint and adductor longus. It may be present in 30% of cases also. That is why there is a lack of consistency of its technical to know whether it is blocked or not. Now, what does it supplies? It supplies the hip joint, it supplies the knee joint. It supplies a part of the area of here, medial side of thigh, lower side of thigh. This is the place. It also subcutaneous supplies the pectineus, external obturator, longus brevis and magnus and gracilis muscles. So it controls the adduction and rotation of the thigh. So these are all the sensory nerve supply is a little inconsistent, probably here. Joint is here and here. The three adductors, longus brevis and magnus, gracilis. Previously we saw pectineus and obturator externus. These are the muscle supply of obturator. Now we can also see here pectineus, obturator externus. The obturator nerve comes here. I would also want to thank the internet for taking up the picture and slightly modified this. And here, slightly modified this. Here, this is the proximal block and this is the distal block. Longus, brevis, magnus, gracilis, pectineus, obturator externus. So what are the indications? Before that, you can see this is the posterior branch. You see the posterior knee, medial side. There is some innervation of the knee joint. Obturator nerve block for transurethral resection of bladder tumors. This is the number one indication. TURBT. Sometimes we can have for knee surgeries, we can have for TKRs, we can have for ACL reconstructions. Why you are very much worried about this obturator block in TURBT? Now they are putting this cautery into the bladder. They are stimulating the obturator nerve. Then the adductor will close. The lithotomy position is difficult to maintain. The hip will adduct. So why it is doing? We are giving spinal here. And this is, if you touch here, this is going through this and there is no pain. But here the efferent nerve in the bladder, if you stimulate the obturator nerve fibers, it is likely to miss whatever it is. And then adductor muscles will contract. So that is why we need a separate adductor block, even though the spinal anesthesia is there. Does the front of the hip has got more nociceptors? Because we are more worried whenever there is a hip pain, we give obturator nerve block, femoral nerve block. We forget about this sciatic. Why? Because probably the nociceptors are there more in anterior and mechanoceptors are more in the posterior. That is why we target femoral and ONV for any hip pain. So we know this, these are all the indications. Persistent hip adductor spasticity as a complication of these things. Yes, we can have obturator nerve block. Diagnostic obturator nerve block for inguinal and back pain. So now we have given the obturator nerve block. How to evaluate this? Because the skin is medial side of small portion. Only the adductors have to be examined. Maybe some portion here. So now we have to extend both the knees, dorsiflex the ankles, and then squeeze a blood pressure cuff between the thighs. Now what I am going to do, see here, there is a blood pressure cuff. There are new instruments for this now. This blood pressure cuff is inflated to 40 millimeters. I am holding this leg, it cannot move. Now this fellow is adducting here. This pressure will increase from 40 to 80 millimeters of mercury. Now I have given the block here. This adductors is gone slightly. Now again I am holding. Now this fellow presses again. He cannot move beyond 40 to 60. That means a 50% reduction is there in the adductor strength. Means your obturator nerve block is working. What are the techniques? This is how we should evaluate adductor muscle strength, because the sensory innervation is very variable. What is the technique of blocking? Classical, nerve stimulator, and ultrasound. Now position is supine with legs in a slightly abducted position. Spirit beware. Now the pubic tubercle should be located at an X. And you mark another X 1.52 centimeters lateral and below the pubic tubercle. The needle is inserted at this point. You will hit the bone, then slightly withdraw and go horizontally slightly 1.5 centimeters. You will be mostly in the obturator canal. Then inject 15. Previously, without anything, they used to inject 20 to 25 ml of the local anesthetic solution. It will spread in the obturator canal to block the obturator nerve. Now you can see this is the pubic tubercle, 1.5 to 2 centimeters medial and inferior. This is the point we should get the needle straight in and then slightly horizontal into the obturator canal. 2.5, sometimes 4 centimeters only the obturator canal. See here, this is the initial thing and this is the redirected thing. Large volumes, minimum 15-20 ml should be there. There are two approaches. One is pubic approach, another is inguinal approach. Now the pubic approach is classical. Pubic tubercle 1.5 to 2 centimeters. In the inguinal approach, you palpate the femoral artery and you palpate the tip of the adductor muscle tendon line and then go to the midpoint. This is what is called the inguinal approach and use the similar technique. Nerve stimulation. If you use a nerve stimulator, adduction of anterior medial thigh. Medial thigh anterior. Posterior division, medial thigh posterior. Now we have known that this is classical approach, nerve stimulator basis, and all these things are almost getting eliminated. We are going to ultrasound guided obturator nerve block. What is distal approach? I told anterior and posterior division has to be separately blocked and we need 2 injections. What is proximal approach? Only 1 injection is needed. Probably we are going proximally and we are blocking the main branch. Yes, there are so many approaches. Akaya, here there may be a probe like this, or a probe may be here, and this is the adductor longus, brevis, magnus, and vertical, horizontal, and patient in the lithotomy position, supine position. So many approaches is there to keep the probe. Supine, abducted, externally rotated, placed below the inguinal grease to identify the 3 muscles. Local anesthetic between, yes, that is what I have told previously. The anterior branch can be blocked between LB, also slightly go above, pectineus and B. This is also possible. Subsequently, now you have brevis and magnus, posterior division. Proximal approach, drug deposition between obturator externus and pectineus. There are innumerable approach. Sometimes a thick fascia of obturator externus is there. Superior vesicle, target the artery. There are so many approaches. Anak, North Palau, Taga, Lin, etc. Proximal approach is single injection. Distal approach is 2 injection. We can use nerve stimulation guidance as a dual approach. Now I am again telling you, these are all the adductor muscles. This is the pectineus. This is the obturator externus. I'm going this way. Now, this is the obturator nerve. We should always see the injection pressures because sometimes it may go into the muscle, sometimes it may go into the fascicle, all these things. So various ramifications. So this is the more of a proximal approach. Tips. Percutaneous radio frequency lesioning and pulse of the obturator. Yes, it is possible with this. Anatomical considerations for obturator nerve block with fascia iliaca compartment block. I'll come there. So many approaches. What is the way? Ultrasound orientation, transducer position, tilt, beam, stimulation, patient position. There are so many approaches here, which I have already told. Inguinal, vertical, horizontal, in lithotomy position, when in plane, out of plane, all these things. Now you see here, this is what I told. The anterior branch can be from L and B, and also from B and pectineus. Now, in between pectineus and obturator externus, if you give here, this is the proximal approach. We can go slightly up also. Now, but we should be careful about the obturator artery here. This is the pectineus and this is the obturator externus. And keep it here, you can see the artery. Again, I am telling you, this is pectineus, obturator nerve, obturator externus. These are the three adductors. These are the three adductors. 1, 2, 3. Pectineus, obturator externus. Certainly go above. That is what. Now it is the other way around. We can see here the video of the. It is coming from here beautifully, and the needle will come. You see here. The needle will come the next video. This is the obturator nerve. Now the needle is injecting here, and this is more of a slightly lower down distal approach slightly, and we are injecting to the anterior division some 7 or 8 ml, and then we are going into the posterior division after removing the needle, and the needle is again coming back here. Needle is coming back here and going here, go there, and going in between the B and M, and then injecting here. So this is a distal. If you give 2 injections, then it is a distal approach. Now you can see the local anesthetic, dilatation, black spread. Removing the needle now slowly after injection. Slowly again coming back and injecting here. An obturator nerve block does not alleviate postoperative pain. See, if you want to give only obturator nerve block, there are a lot of confusion. Only it may not be very good for alleviating postoperative pain. But if you this technique of most extensive care does not lead to operative FICB block. This is another article. May not actually give operator nerve block, but yes, there are certain things now comes suprainguinal approach. Go above the FICB and then give. It may get the operator nerve may get bait by the injection above, but classical FICB operator nerve is likely to be spared. Pen block, articular branches of obturator and accessory nerve block. Here is the see, you can see the psoas muscle, femoral artery, femoral vein, femoral nerve, all these things. These are taken from the internet for academic use only. Addition of ON, but here, if you have femoral triangle block and then give ONB, it is better for TK. ONB alone is not good for THA, but ONB with FTB may be slightly better for a knee surgeries. Effect of ultrasound, whether proximal or distal, obturator nerve block to use dissection doesn't matter much, is one article. Ecosphenol can reduce hip adductor spasticity. Now, what these are all the various things of obturator nerve block. What are the complications? Yes, failure is the most important. It is not working because it is very difficult technologically to see this. Difficulty in assessment, whether it is working or not working, we may not know. Neural damage and vascular puncture because arteries are there. So external obturator externus, pectineus, these 3 adductors, superior pubic ramus. This is how to give 10 ml or 15 ml here. It will go like this. You can see the eruption like this coming out, and which we saw in the video. We know the complications: failure, obturator nerve injuries, obturator vascular injuries. Thank you. My slides are available in painfreepartha.com, and my channel is painfreepartha. Subscribe.